Just give everyone a moment to log in and get connected. All right. Thank you everyone for joining us today. This is the 5th webinar in the Dravet Syndrome Foundation's Listen and Learn Professional Education Series. We'd first like to thank our educational sponsors who made this possible, which include Greenwich Biosciences, Neurelis, Zogenix, Encoded Therapeutics, and Stoke Therapeutics. We would also like to thank the American Epilepsy Society for their partnership with DSF to provide CME accreditation for this series. We'll be sending emails following the session today with instructions for claiming credit, so look out for those. Lastly, all registrants should have received a link to a survey to assess your baseline knowledge of Dravet syndrome prior to accessing this webinar series. We'd ask that you please keep an eye out for a follow-up survey after the live series completes on November 16th, and consider taking a moment to fill the survey out, even if you were unable to complete the pre-survey. As we go through the talk today, please feel free to drop any questions you might have in the chat, or it would be great if you held them to the end and asked yourself over video or audio. With that, I would like to introduce our speaker today, who is Professor Ingrid Schaefer. She is a physician scientist whose work as a pediatric neurologist and epileptologist has led the field of epilepsy genetics for over 25 years. Professor Schaefer has described many novel epilepsy syndromes and refined genotype-phenotype correlations. Her major interests are in the genetics of the epilepsies, epilepsy syndromology, and translational research. She is chair of pediatric neurology at the University of Melbourne, a senior principal research fellow at the Florey Institute of Neuroscience and Mental Health, and director of pediatrics at Austin Health. We are very lucky at DSF that Dr. Schaefer kindly serves on our medical advisory board, and we are just so grateful to have her here speaking today about defining Dravet syndrome. Thank you, Dr. Schaefer.
Thanks very much, Veronica, and thank you to the Dravet Syndrome Foundation for what you do. I'm huge admirers of DSF, as any of my parents that I work with will tell you, because I always say DSF is the best model. And this is just another example of the great work that you do. So I'm excited today to talk to you about what is Dravet syndrome and have we got it right when we teach people about it and how we define it. So here are my disclosures, and now to move on to the learning objectives. Well, the objectives of this talk are to understand the whole phenotypic spectrum of Dravet syndrome, to use evidence for us to redefine the diagnostic criteria for Dravet syndrome, and to do this in order to allow early diagnosis for babies with Dravet syndrome, so that we are ready and primed for precision medicine options such as gene therapy. So I know many people will be aware of the puzzle that I've used for many years to teach about Dravet syndrome. And the concept of the puzzle came about because I was trying to illustrate the complexity of this diagnosis. And as you know, babies typically present at around 6 months. They're previously well developmentally normal, and then they present with a prolonged seizure. It's usually triggered by fever. It's jerking down one side or sometimes generalized tonic-clonic, so both sides. And then the baby goes on from 6 months to 12 months to have fairly frequent convulsions, like once a month or once in 2 months. Then between 1 and 5 years of age, they develop other seizure types, including focal seizures, myoclonic seizures, absence, and what the French call obtundation status and what we call really non-convulsive status epilepticus. So just to illustrate some of these additional seizure types, here you see a little 21-month-old boy, and he's being shown the photic stimulator, and it triggers a cluster of myoclonic seizures. It's not a tonic-clonic seizure because at the end of it, he screams and says, I didn't like that very much. And that shows us, so let's play that. It's quite an old video, but it's a good one. And you can see the stimulator, he's clearly photosensitive and now he's screaming. And we haven't got the audio on, which we'll be grateful for. So that's a cluster of myoclonic seizures in a photosensitive child with Dravet syndrome. But not all Dravet children are photosensitive, only about 15%. Okay, here's another little boy I look after, and he has little absence seizures when his eyes close and he has some eyelid fluttering. These are special absence called absence with eyelid myoclonia. There he's looking at my phone, and you'll see there's another one right there. And then he's back, he's quite interested in my phone, and there we have another little cluster with a bit of a head jerk towards the end. So these are called absence with eyelid myoclonias, just to show you. And here's the same little boy, a little bit older, and he's there having a little seizure there, but now you can see more prominent myoclonic seizures as part of that. So with the head nod as well, but you see the little cluster of jerks there. So this is a absence with eyelid myoclonias, but also some myoclonic seizures in there. So in Dravet children, we know that their early development is normal in the first year of life, and then development slows or plateaus. In our gait studies, we found they walked a little late. So the upper limit of normal walking is 16 months, and they walked at 16 to 18 months on average. Their language acquisition is then slow in from age 1 to 2 years. And many of the parents will report that the child regresses with the prolonged seizures, and they take a few weeks to catch up, but do they really catch up? Almost all patients with Dravet syndrome have intellectual disability, and ours and other studies have shown that 50% of children and adults have severe intellectual disability, 30% are moderate, 20% are mild, and they're very rarely normal by the time they reach adult life. I think I have one patient who's normal in adult life. So what about examination finding? Well, in the young child, they have unsteadiness or physiological ataxia, so they walk a bit late and they're ataxic for a bit longer. But then as they grow older, they develop mild pyramidal signs, which you'll miss unless you examine them. And by that, I mean after puberty. They develop this interesting posture, which we were the first to report with my colleague Jill Rodder, who's a postdoctoral physiotherapist. And you can see here this crouch gait where there is hip flexion and knee flexion. And our studies showed that whilst it didn't affect their ability to walk around the house or even to run in the back garden, it does limit their long distance walking. And as they grow older, people often have to use wheelchairs. The EEG is normal in the first couple of years of life, even though the child might be having quite frequent seizures. But then a lot of epileptic activity becomes apparent. And this is both irregular generalized spike wave, as I show here, but also multifocal discharges are very common, and also polyspike wave, which you can see here. So the last piece of the puzzle, of course, are the genetic causes of Dravet syndrome. And when we teach, we usually say more than 80% of patients have a mutation of the gene SCN1A. And that encodes this alpha, the purpley colored alpha subunit, which sits in the cell membrane. It has 4 transmembrane parts. And this is the pore-forming subunit of the ion channel through which the sodium ions pass. And so more than 80% of patients have mutations of SCN1A. This is from the original data, originally identified by a Belgian group of Peter de Jonge, Claes et al. And then, of course, now there are more than several thousand mutations or pathogenic variants, is the words we use nowadays. And about half of them are shown in red, a truncation, half are blue, missense. But then you have other special types of pathogenic variants, splice sites. You can have small intragenic inside the gene deletions or larger deletions, deleting a whole gene. Now, we also know that more than 90% of these children have new gene mutations in them, but some of the children may be mosaic, and that means they have two populations of cells, the normal population, the normal cells, and then cells with a mutation. And yet, even though they may not have the full heterozygous mutation, they may still be just as severe. In the cases where the mutation is inherited from the parents typically are more mildly affected with febrile seizures or febrile seizures plus, so presentations within the GES plus spectrum, which I'm sure you know is genetic epilepsy with febrile seizures plus. So all of this together makes up the puzzle that we think of as Dravet syndrome, and that is what most of the Dravet doyens around the world will teach you, including myself, when we teach about Dravet syndrome. But is that right? And this is a slide that really is just to say, what about the fuzzy edges? And by that, I mean, what about the people that don't quite fit Dravet syndrome and they don't do it all by the book I've just told you? Have we got our syndromic definition wrong? So we ask these questions: at what age can you actually diagnose Dravet syndrome as a pediatrician or neurologist? Do you need the whole hand of features, like all the pieces of the puzzle? Because often that's not really apparent till a child's 3 years of age. And by then the horse is bolted probably, and it's a bit late. Do you need to wait for the first episode of status epilepticus, remembering that that is defined as a 30-minute seizure, be that convulsive or even a focal impaired awareness seizure or non-convulsive status epilepticus? Or is the first not enough? We know that 11% of babies presenting with febrile seizures will have febrile status epilepticus. Can you diagnose Dravet syndrome with the first seizure, or do you need the second one? When is it enough? And what about those patients that just don't quite match the typical feature? It's too long for the next seizure, their development's not quite right. So we asked these questions with the three of us, Dr. Huanhui Li, who is a pediatric neurologist from Shanghai, and she came to work with my team for about a year. And a huge amount of work has been done by Amy Schneider, who heads my Dravet studies and has done many, probably a year's worth of work to get us to this point. So with our Fuzzy Edges project, the aim was to delineate the limits of Dravet syndrome. Can we make a diagnosis if the patient has atypical features? Why does that matter anyway? Can we just wait? Is it really a rush? Well, that is because with a delayed diagnosis, you may give the wrong medications to a child, and they may then have adverse effects, and then that may affect how well that child develops. And that then may affect long-term cognitive outcome. And also, excitingly, we're on the precipice of precision medicine trials with gene therapy trials already working in animal models, and we're just starting to think about them in human models, humans, not human models, in our little patients. And the question is, we need to have something to compare it with so that we can pick the right children for those trials, and then we need to understand the natural history of the disease. So this just is an illustration from just 2018. A very good child neurologist saw this child, didn't recognize it was Dravet syndrome. You can see the child presents at 4 months with the red line denoting their first seizure, was placed on Keppra, levetiracetam. The seizures kept, sorry, that's not right. The green is the levetiracetam. The Keppra, you can see the seizures kept happening. So here, between 12 and 13 months, the neurologist started Trileptal or carbazepine, which is closely related to carbamazepine, both of which are sodium channel blockers and are really the worst thing you can give a child with Dravet syndrome, as the child shows very clearly with this immediate takeoff of their seizures, lots more seizures. And we know when children have more seizures or they have episodes of status epilepticus, that their development goes backward or plateaus, and this can affect long-term outcome. So in this study, we looked at the fuzzy edges in 188 patients with Dravet syndrome who all had pathogenic variants of SCN1A. And we analysed their early clinical features using parental interview, a validated seizure questionnaire that we've used since 1992. It was first published, medical histories, seizure diaries. We really went for all the source data we could. So in our cohort, 56% were female. The median age at study was 18 years, but you can see they ranged from 1 to 61 years. And here is the breakdown of their pathogenic variants, with the vast majority of the SCN1A pathogenic variants. And as you can see, as most of the studies show, it's 40% missense, 40% truncation, which is what we found, some splice site, a few deletion, and other. So here are the questions that we asked. In Dravet syndrome, is onset under 12 months of age? And there is a fairly recent high-level Italian study that says Dravet syndrome is defined by onset under 12 months of age. So we asked, is that really the case? And here you can see the onset ages in our cohort, and you can see a nice normally distributed curve. And here are a few outliers from the 12 months of age. Our median was 5.75 months, which goes with our teaching of an average onset of 6 months of age, so that's correct. But we do have these outliers of 3 after 12 months. You can see here that these 2 patients are truncation mutations. Now that in itself is interesting because people tend to think that truncation mutation patients are more severe than patients with missense mutations. If you look at the work from Samir Zuberi and Andreas Brunklaus, the differences there are minor, like it might be a month or 2 months between onset of different seizure types, maybe a month or 2 months earlier in the truncation mutation children, but in general, they're very similar. And so it's just interesting that the more severe type of mutation is associated with later onset, saying that really there's not much difference. Interestingly, we had one patient who began at 20 months of age who had a missense mutation. And then we looked at the literature, and you can see here there are a lot of patients that begin between 12 and 20 months of age. So really the cutoff under 12 months of age is not supported by looking at the reported cases. Now, the other interesting point is that our patient who began at 20 months of age actually was mosaic and had a relatively low proportion, 22% of cells had the pathogenic missense mutation. So in my mind, I started to think, well, maybe if you're mosaic, that means you have a later onset. So then we went back and looked at our case series, and we have this patient here who's 30% mosaic and begins at 10 months of age. And in fact, he's got a very severe seizure phenotype with 600 seizures a year when he was a younger child, convulsive seizures. And then when you look further at the very good paper from the Dutch group of De Lange and colleagues, you can see they described that 7% of their population, 7.5% of their population of patients with Dravet syndrome were actually mosaic. And you can see the ages of onset are really the same as the rest of the cohort. So mosaicism doesn't necessarily mean a milder phenotype. And in the De Lange paper, the variation in the mosaicism was quite broad, from less than 22% up to 40%. So let's look at the next piece of our puzzle. And in this, we're looking at the first seizure type. And we tend to think of it as a febrile seizure with jerking down one side, or perhaps a generalized tonic-clonic seizure. So what do the data show? Well, how many of our patients had a fever with the first seizure? Based on clinician report or parent report, only 54% had a fever with their first seizure, and 46% did not. The median temperature was 38 degrees Celsius, and I think that's a very interesting feature of patients with Dravet syndrome, that they tend to fit at lower temperatures than a typical febrile seizure child. Children with febrile seizures, 3% of Caucasian children, will fit, but they tend to have a tonic-clonic seizure when they're 39, 40, more likely 40, 41. And the Dravet children tend to have a seizure a little bit at lower temperatures, which is always a bit of a red flag to me. Now, this is interesting. Over their whole course of their disease, we found 6 children who never had seizures triggered by fever. So again, I guess debunking the fact that they must have febrile-related seizures, although it's only a small group of the total cohort. So what about the first seizure type? Do they begin with hemiclonic most commonly? And the answer is no. I was surprised to find this. Only a third begin with hemiclonic seizures. Usually they will have them on either side, obviously independently, right one time, left the next. But about 16% only ever had them on the one side through their illness, 16% of the 32%. You can see the most common presentation was with a generalized tonic-clonic seizure, which occurred in 54%. But there were other presentations as well. You have 7% beginning first with myoclonus, and Charlotte Dravet herself described that originally. Focal impaired awareness seizures, the new terminology for complex partial seizures, which we don't use anymore, but just if that's the phrase you're used to. 1% presented with absence seizures, and 3% presented with several different seizure types at once, so absence, myoclonic, etc. And so the take-home message here is that the most frequent initial seizure type is of a generalized tonic-clonic seizure, and that's actually more frequent than hemiclonic. So then let's move to the duration of the first seizure. As I've said, we always think of it as tending to be prolonged. So is that the case? Well, actually, we found it wasn't. Only a third presented with a prolonged seizure. And you can see quite a few presented with a 16 to 29-minute seizure. So again, one of the pointers in my brain when I see a child with Dravet syndrome, if they're prone to more prolonged seizures, I tend to think that's very Dravet-like. Even more than 6 minutes or more than 5 minutes is Dravet-like. And if you look, most of our cohort fits into that group. But interestingly, 29% presented with their first seizure was brief, under 5 minutes. And if we drill down on that, you can see that, in fact, 21% of those, of that total cohort is presenting under 3 minutes of age or less. Sorry, under 3 minutes duration or less. So it's important to know that a Dravet child may present just with brief seizures and not have the prolonged pattern. All right, now this is a bit of a complicated slide for which I apologize, but just to look at the first 5 consecutive seizures, because we tend to think of Dravet children as having status epilepticus. So we've just talked about the fact that about a third present with status epilepticus. The second seizure and this is the numbers here denote those children on whom we had accurate data, because we didn't have it on everyone, of course. And you can see the second seizure was status in about 25%, but they get less and less frequently to be status by the 5th seizure. And if you have a look here, the yellow shows the brief seizures, which increase as the child grows older. And I'm sure we've all seen that, where the children begin with status, but then their seizures become briefer. All right, and so looking at this duration in a slightly different way, just to show you the median duration of over the whole cohort from the 1st to the 5th seizure. So this, but also the maximum duration. So some of the patients still do have status epilepticus at their 5th seizure, but the median duration comes down quite noticeably from 15 minutes to 5 minutes. So 5.5 minutes is still longer than your average febrile seizures. So, you know, again, the flavor that Dravet children have longer seizures and that they don't always have status epilepticus. All right, now we were asked in the data, we looked at it in a slightly different way, and we said, how long is it between your first seizure and your second, and then your second to your third, etc., up to your fifth? And the data, again, were a little surprising. The average duration between first and second seizure was 29 days. But the important take-home message is that some people take a long time to have their second seizure. So you can see all of these patients here are out to over 6 months. So you might present at 6 months and then not have your next seizure until 12 months. So it's much further than we think. Very important, because sometimes people think that Dravet can't present with that long spread out time frame. Similarly, second to third seizure is also very similar, 28 days, but again, this long spread out. So you can imagine that one patient may have 3 seizures over 18 months or something. It becomes much tighter thereafter. From third to fourth seizure, it's 18 days, and then fourth to fifth seizure, it's 17 days. And you can see that there are far fewer outliers. So just again, a reminder that it may be longer between the initial seizures than you think of the Dravet syndrome. All right, so then we've been talking about the additional seizure types that you get after your first convulsive seizure, and we can present with an array of different seizure types. So how long does it take for the child to develop a new seizure type? And we've already talked about the initial seizure type presenting at 5.75 months with a median, a minimum age of 6 weeks, and a maximum age of presentation, as we started with, at 20 months. And there's the 12-month mark. Now, in general, we've been teaching that the additional seizure types occur between 1 and 4 or 5 years of age. But is that right? And no, it's not. We found that the median age of the second seizure type was actually 9 months, but could begin as soon as 2.5 months of age and could take to 10 years to develop. And the third seizure type, yes, that's into the second year of life, a median of 16 months. But again, you could have all 3 seizure types by 4 months, or they could, the third seizure type in patients that had a third seizure type, and not all do, we had developed by 6 years of age. And what are these additional seizure types? Well, these are the ones we've already talked about: tonic-clonic. The second most common seizure type is myoclonic, about the same as hemiclonic, really. Then focal impaired awareness seizures, then absence seizures. But what about other types? 25% of patients had tonic seizures. We know that they're more common in an adult life, but we did find them early. We found that 23%, similar percentage, had atonic seizures, atonic drop attacks. We found that not everyone has convulsive status epilepticus at some time, but overall 91% did, and about a third had non-convulsive status epilepticus. And as I've mentioned already, not everyone has seizures triggered by fever, although 97% do. So what about the order in which these seizure types come out? Well, after tonic-clonic seizures, as we've talked about, is the first seizure type in about 54%. It's the second seizure type in the orange shown here, a third here, and in green, it's where it's the fourth seizure type or more. So you can see here the order I've just described to you, but you can also see how people develop these additional seizure types. And what's interesting is the tonic and atonic seizures tend to occur in children who have had multiple other seizure types. So they're sort of only seen in probably the most severe ones. So let's take our next piece of our puzzle and say, well, we teach that children are normal until the first year of life, and then they show developmental slowing and or regression. So looking here, there's our 1 year marker, and we actually found that 23% of patients showed slowing before 1 year of age, and then 50% have slowing in the second year of life, which is what we teach. But interestingly, up that end, up the older end, 3% have slowing not until they're 5 years of age. And you do see this in the milder children. You think they're fine. And then when they hit towards the end of primary school, it becomes very clear they're not quite fine. So developmental delay. Oh, and then in addition to these findings, we found that 4 patients were never normal, which is certainly against the teaching. We found that 4 patients were always abnormal and then became developmental slowing or plateauing, and that the range of developmental slowing and plateauing is from 6 months to 5 years, with the median at 21 months. So what about then the EEG features? And I'm not going to spend time talking about them, but I did want to talk about mortality in Dravet syndrome. And we often teach that patients with Dravet syndrome have a mortality of 17% by 20 years of age. This is a well confirmed piece of data by Japanese studies, French studies, and our own studies. And this is just to show the different causes of the mortality, which in blue is sudden unexpected death in epilepsy. And I know that's really what the families are very fearful of, which is very understandable. But you also have status epilepticus, which is shown here in grey, and accidental causes in orange, such as drowning, that sort of problem. And we know that with the status epilepticus, you can have brain swelling, which we reported a few years ago with my colleague Ken Myers, where you get the child has a long seizure and then goes to the intensive care unit, and then on MRI is shown to have very severe brain swelling and with multi-organ failure due to the hypoxia, and they succumb. So this is the broad picture of patients with Dravet syndrome. So how has this study changed our thinking? Well, I think it makes you realise that Dravet syndrome is a broader spectrum than we have thought until now, and development is not normal in the first 12 months of age in almost a quarter of patients, where it's delayed prior to 12 months of age. The onset is very broad, from 6 weeks of age in classical Dravet syndrome to 20 months of age. Bilateral tonic-clonic seizures are the most common presenting seizure type in 54% of children. 46% of children do not present with a fever with their first seizure, and 29% of children actually present with a brief seizure, and so would not stand out by any means from your average febrile seizure. Additional seizure types typically begin before 12 months of age, so it's our job as clinicians to ask families very carefully, because they may not recognise the subtle awake myoclonic seizures that you can see, or absence seizures. A third of patients do not ever have hemiclonic seizures. 9% of patients never have status epilepticus. 3% never have fever sensitivity, and about a quarter have tonic or atonic seizures, again, not well recognised in Dravet syndrome. So this is our puzzle, and one of the last piece of the puzzle was that 80% of patients have SCN1A mutations. So we looked at our cohort and said, is that right? It feels like more of these patients have SCN1A mutations. So here are our data of 138 definite in our studies, and 159 includes the probable. And we found SCN1A mutations in 93% of the definite, 92% overall. We did have some other different gene mutations, which we've reported some years ago with Gemma Carville and Heather Mefford, GABA-G2, GABA-A1, and SCN1B. And so our solved rate is now well above 90%. And I think we can change the story there to saying that it's above 90%. And really for us, it's sitting around the 95% mark. So just to return to my puzzle and the fuzzy edges, I think we need to question some of what we've written there and say, well, the median presentation is 6 months, but if they can begin before 20 months, they may or may not have a fever, and prolonged tonic-clonic seizures are more common than hemiclonic. These are the other seizure types. They walk a bit late, and more than 90% now have SCN1A mutations. Now, I didn't want to finish just there because I know that some of the patients that you might see will return an SCN1A pathogenic variant, and yet they don't quite look like Dravet syndrome. And I just wanted to talk about a more severe SCN1A developmental and epileptic encephalopathy called early infantile SCN1A developmental and epileptic encephalopathy. So before this new syndrome, we thought about SCN1A epilepsies as the mild end genetic epilepsy with febrile seizures plus or GIFs plus. It's only found in 10 to 20% of GIFs plus families. And then, of course, the big group of Dravet syndrome. But what about this pointy end? And this is this very severe phenotype. And I described this with my colleague Lynette Sadlier back in 2017 now, and said, well, you can be even more severe with SCN1A. And it's important because I've just told you that some classical Dravet children begin at 6 weeks of age, 6 or 7 weeks of age, and so do these children, but they look quite different. So in our original study of this, and I'm now aware of other patients around the world being recognised with this disorder, we happened to have 7 boys, but I think that was just chances, low numbers. And they were 6 to 12 years of age at the time of study. Now, they all had seizure onset prior to 12 weeks of age, so under the 3 months mark. So if you have a patient with an SCN1A mutation and they're under 3 months, you have to think, could it be this or could it be Dravet syndrome? And 5 of these children, these boys, presented with hemiclonic seizures and 2 with generalized tonic-clonic, so that looks like Dravet. But there were major differences. Of this group, almost all had tonic seizures, and well, 5 out of 7 and 5 out of 7 had epileptic spasms. You don't see epileptic spasms in Dravet syndrome. So if a child has spasms, then you must think about this disorder, or if they have very prominent tonic seizures. Now, we're not sure if these children were normal prior to presentation. The families thought so, but they haven't really been examined prior to this. But they all are much more severely developmentally delayed than a child with Dravet syndrome. So they have profound impairment. They don't walk and they don't talk. The other very important feature is that a movement disorder developed in all of these children, and that began as early as 9 weeks of age or up to 20 months of age. And let me show you 3 unrelated boys, all with the same mutation, and you can see they've got a very similar movement disorder of which we call hyperkinetic with chorea. They have dystonic posturing of their hands and their fingers, if you look, and they also have this very prominent orofacial myoclonus, not something I've ever seen in a child with Dravet syndrome. Their EEG was normal initially, and then was similar to a Dravet child with generalized and multifocal discharges. And the other fascinating point about this group of children is that they had 6 of the 7 boys shared the same mutation, a threonine 226 methionine missense mutation. And as you'll recall, I said that they're 40% truncation, 40% missense in Dravet syndrome. And we tend to think of truncation as worse. But in fact, here we have a missense mutation that is much worse than Dravet mutations. It's recurrent, so it's very robust, and they all had a very similar clinical picture. So my physiology colleague, Geza Barecki and Steve Petrie's lab, looked at this very carefully in cells to see, does it have a different functional effect? We postulated that this SCN1A early infantile developmental and epileptic encephalopathy would be due to a gain of channel function mutation, as distinct to Dravet syndrome of GIFs plus. This has been very beautifully shown by many physiologists to be due to loss of function, so the function doesn't work very well. The ion channel doesn't work properly. The reason we thought that maybe the early infantile developmental and epileptic encephalopathy was due to gain of function was that it resembled SCN8A and SCN2A, early infantile developmental and epileptic encephalopathy, in terms of its severity and the movement disorder. So Gazer asked this question in vitro and found that indeed the cells did show gain of function. And why is this important? It's incredibly important because it means that they may benefit from sodium channel blocking drugs such as carbamazepine or carbazepine, phenytoin, or perhaps lamotrigine, whereas those drugs can make Dravet syndrome worse, particularly carbamazepine and oxcarbazepine. I don't think we're definite about the others. So it really is important to diagnose this other syndrome because a gain of function would require completely different treatment. And this also then pertains to the development of gene therapies, because if we're going to identify children with these mutations early and understand their phenotype, which of these different SCN1A phenotypes, that is going to determine their suitability for gene therapy trials, which is just around the corner. I think one of the companies has already given a first dose of gene therapy as a test dose to a human. And we know there are several companies working in this space with different types of gene therapy. So we as clinicians need to be able to say where the child fits in order to be able to ensure they get the gene therapy at the right age and the right patient. So in my talk, I hope I've given you some clarity around defining Dravet syndrome and understanding really where our limits, where we've defined it, are correct and where they're not quite right. And we need to make sure we get this right for early diagnosis, optimization of therapies, and be ready for precision medicine trials. So getting rid of our fuzzy edges, I've put up the Sydney Harbour Bridge just to have a little bit of Australia there. And in conclusion, I wanted to firstly thank you for listening and acknowledge our fantastic families. And this is actually a picture from our Getter family conference. And here you see one of the children with the profound, the very severe early infantile developmental and epileptic encephalopathies. But you see here a fantastic group of Australian families to whom I'm certainly indebted. They've been wonderful with our research program. Some of my highly esteemed colleagues who work very closely with me. And I also wanted to acknowledge my colleagues around the world, particularly Heather Mefford and her team. And this work that I've presented today is the work of Amy Schneider and Wanhui Li. And so with that, I'll thank you very much for listening, and I'll go off presenter view so that we can have a conversation.
Great. So if anyone has questions for Dr. Sheffer, this would be a great time to jump in. So I'll give everybody a second. And if no one's ready to jump off, I can start with a question if you don't mind. So it seems, as we know, and I think you exemplified even more so of what a spectrum Dravet syndrome is and how there can be in almost every aspect outliers that don't fit the classical definition. And so how as a clinician do you decide at what point it is Dravet? Do they need to check X amount of boxes across of these, or how do you make that call?
We put together an analysis of the data. Amy and I really worked at that, and we felt that they had to have one of three things, 2 out of 3 points. Fever-sensitive seizures, point number 1. Point number 2, hemiclonic or tonic-clonic seizures, and 3, status epilepticus. And if you have 2 out of 3 of those, together with an SCN1A pathogenic variant, I think that's when you can call it.
Okay. else has anything?
Very happy to take any questions from anyone else if they have some.
I can ask another question if we don't have any brave takers. And this, this might be a question I'm a little more ignorant about because I didn't know about this early onset SCN1A gain of function. I had read another report, and I'm blanking on who had put it out, about another SCN1A gain of function. And those researchers were sort of arguing that with time, it almost ended up sort of through compensatory mechanisms looking like similar to the loss of function. And I wondered if you had heard anything about that. And so if that would lead you to question using the sodium channel blockers in that scenario.
Okay, I'm wondering, are you talking about cellular experiments, Veronica?
I think they had done both. So I think they had, modeled these gain of function in vitro with cell.
Yeah, I'm wondering whether, I think that might be the paper I'm talking about, where it starts with gain of function from Gazer-Barecki in Annals of Neurology, and then it sort of wears out quickly, which is, you know what I mean? But it doesn't mean they look like a Dravet patient at all.
Okay.
So it's important to separate the in vitro studies from the people. And I think what you're talking about is that Gazer showed it was overactive, and then it wore out quickly.
Right.
But these children look very different, and I think it's incredibly important that the clinicians recognise that, because it looks like just you're sort of. I remember when I first got the result back on a child with this very severe phenotype, I looked at them and went, oh, it's not Dravet syndrome. I don't believe that. And then Lynette spoke to me about a child in New Zealand and said, have you ever seen this with SCN1A? And I said, well, I've got this other patient. And then we compared them, and then we looked at their mutation. It was exactly the same mutation. And then we went, oh, this is important. So, I mean, that's how clinical research works. Your patients teach you everything, and their families, and then you start to think about it. So I don't think that the in vitro experiments mean it ends up looking like a Dravet. It just shows the channel stops functioning because it's sort of exhausted, I think.
Great. Thank you for clarifying that. Appreciate it. Give anybody else. Does anyone else have another question? If not,
I think you're done there.
Yeah, I would just like to throw up really quick. Let me screen share that just in October of this year, Dravet syndrome did get its own ICD-10 code.
Oh, fantastic. I didn't know that. That's really important.
So it's still rolling out, but there's now these 3 codes that should be part of the ICD-10. So I think most clinics should have this now updated in their system, although there may be some that don't update until the beginning of 2021. But so we've been wanting to educate clinicians and our patient community that these are now live, and hopefully this can help us track mortality and morbidity more closely, and also help patients get clearer access to care through insurance approvals and things. And with that, I will just